Afternoon, everybody. Thanks for this kind invitation to share with you our data about the targeting of Toll-like receptor 2 in order to improve the response to chemotherapy and immunotherapy in preclinical models of breast cancer. Breast cancer is still the leading cause of cancer-related death in women, and this is mainly due to the development of resistance to current therapies that makes advanced cancer a still untargetable disease. Several mechanisms of resistance have been identified, but one of the key players in the resistance of breast cancer cells to therapy is represented by a small population of cancer cells, the so-called cancer stem cells or cancer-initiating cells or persistent cells, that are characterized by self-renewal capability and the capability to differentiate, giving rise to all the different cell types that represent the tumor bulk. These cancer stem cells are unfortunately resistant to the majority of current chemotherapies, radiotherapy, and also targeted therapies, and therefore they survive after treatment, and they can start again proliferating and disseminating, giving rise to local or distal relapses. Therefore, the identification of molecules that play a key role in their survival could open the way to the development of more effective anti-cancer treatments. In order to identify these molecules that play a key role in cancer stem cell survival and self-renewal, in the last years, my group analyzed the transcriptional profile of breast cancer stem cells, looking for genes that are overexpressed in this cell population and that play a key role in their survival and function. This led to the identification of several targets, among which we focused on Toll-like receptor 2. That is a cell surface receptor that is usually expressed on immune cells and that can bind both danger-associated molecular patterns that are produced, for example, in damaged tissues or inflamed tissues, and pathogen-associated molecular patterns. And so it's responsible also for the interaction with the microbiota. We demonstrated that cancer stem cells can actively release one of the ligands of Toll-like receptor 2, the dump HMGB1, and that HMGB1, by binding to Toll-like receptor 2, promotes cancer stem cell self-renewal and survival. Toll-like receptor 2 is associated with a poor prognosis in breast cancer patients, and indeed breast cancer patients that express high levels of Toll-like receptor 2 in the tumor are characterized by low relapse-free and overall survival as compared to patients that express low levels of Toll-like receptor 2 in the tumor. In mammary carcinogenesis, we developed transgenic mice that spontaneously develop HER2-positive breast cancer on either a Toll-like receptor 2 wild type or knockout background. And as you can see, the Toll-like receptor 2 knockout mice have a delayed tumor onset, develop a lower number of tumors, and have an increased survival as compared to Toll-like receptor 2 wild type mice, suggesting that Toll-like receptor 2 is involved in breast carcinogenesis. To understand which is the mechanism, we performed cross-transplantation experiments by injecting Toll-like receptor 2 wild type or knockout breast cancer cell lines into Toll-like receptor 2 wild type or knockout mice. As you can see, Toll-like receptor 2 knockout cells are poorly tumorigenic, while Toll-like receptor 2 wild type breast cancer cells give rise to tumors that grow faster when injected into Toll-like receptor 2 wild type than into Toll-like receptor 2 knockout mice, suggesting that Toll-like receptor 2 promotes tumor progression through both cancer cell autonomous and non-autonomous mechanism. The cancer cell non-autonomous mechanism can be at least in part due to the decreased frequency of T regulatory cells observed into Toll-like receptor 2 knockout mice. And this decrease in Treg cells is due to the fact that Toll-like receptor 2 is expressed at very high levels on T regulatory cells as compared to the expression on effector CD4 positive T cells, and that its activation by either a pump, so a pathogen molecule such as PGN and HMGB1 promotes T regulatory cell expansion, suggesting that the activation of Toll-like receptor 2 on immune cells promotes the generation of an immunosuppressive tumor microenvironment. Besides inducing and promoting tumor progression, Toll-like receptor 2 also favors breast cancer resistance to chemotherapy, and indeed chemotherapy-treated patients that have a high expression of Toll-like receptor 2 in the tumor have a low response to treatment, and so a poor relapse-free survival as compared to patients that express low levels of Toll-like receptor 2 in the tumor. And similarly, we demonstrated that Toll-like receptor 2 knockout breast cancer cells have a higher sensitivity in vitro to doxorubicin, but also to other drugs that induce immunogenic cell death. This is due to the fact that doxorubicin and other drugs and the drugs that induce immunogenic cell death induce the release by breast cancer cells of HMGB1 and several other dumps such as HSP90, HSP70, HSC70 and Morgana, and HSP60 that bind Toll-like receptor 2. And in particular, HMGB1 is released at very high levels following treatment of breast cancer cells with doxorubicin. HMGB1 treatment induces the dimerization of Toll-like receptor 2 with Toll-like receptor 6 on breast cancer cells, which leads to the activation of the NFKB canonical signaling pathway in a Toll-like receptor 2 dependent manner, since this phosphorylation is not observed when Toll-like receptor 2 knockout breast cancer cells are treated with HMGB1. Indeed, treatment of breast cancer cells with doxorubicin induces a progressive activation, a dose-dependent activation of NFKB that is completely abolished when we co-treat the cells with an inhibitor of Toll-like receptor 2, that is the small molecule CuCpt22. Thus, the addition of CuCpt22 is able to increase the sensitivity of breast cancer cells to doxorubicin, but also to other immunogenic cell death inducers, and increases the pro-apoptotic activity of doxorubicin and these chemotherapeutic drugs. As I mentioned before, Toll-like receptor 2 is not only a receptor for endogenous dumps, but also for pumps and bacterial ligands. And therefore, we hypothesize that Toll-like receptor 2 can also mediate the protumorigenic activity exerted by the local microbiota. Indeed, in the last years, the presence of microbiota in the mammary gland has been demonstrated, and alteration in the composition and the quantity of this microbiota has been linked to chemoresistance. Therefore, we decided to understand whether Toll-like receptor 2 may mediate the chemoresistance induced by mammary dysbiosis, so by alterations in the local microbiota. To test this hypothesis, we set up an in vivo model in which we induced mammary dysbiosis by treating mice with intramammary injection of a cocktail of antibiotics in order to induce the alteration of the mammary gland microbiota. And then we injected 41 breast cancer cells in the mammary gland. And when the tumors became palpable, we treated mice with doxorubicin. When we injected wild-type Toll-like receptor 2 expressing 41 tumor cells, we observed that treatment with antibiotics and so that induction of dysbiosis increased tumor growth as compared to control mice. And dysbiosis completely prevented the anti-cancer capability of doxorubicin. On the contrary, when we injected 41 cells in which we silenced the Toll-like receptor 2, we didn't observe any activity of dysbiosis, and the doxorubicin was able to stop tumor growth also in dysbiotic conditions, suggesting that indeed Toll-like receptor 2 may mediate the protumorigenic capabilities of dysbiosis and also the chemoresistance induced by mammary dysbiosis. And we are now trying to characterize more in details the mechanism underlying this phenomenon. To cut the long story short, we have demonstrated that Toll-like receptor 2 induces chemoresistance since treatment with chemotherapy can induce the release of pumps and dumps, pumps from the altered microbiota, so can induce dysbiosis, and dumps such as HMGB1 that are released by cells treated with immunogenic cell death inducing chemotherapies. HMGB1 dumps and pumps can bind Toll-like receptor 2 on breast cancer cells, leading to the activation of the NFKB signaling pathway that induces the production of pro-inflammatory cytokines and growth factors such as IL-6, TGF-beta, and VEGF by cancer cells. These cytokines and growth factors then act through an autocrine or paracrine loop to promote breast cancer cell proliferation, survival, EMT, and invasion, thus favoring the induction of resistance to chemotherapy. Based on these results, we decided to develop combined therapies based on the delivery of Toll-like receptor 2 inhibitors and chemotherapy to the tumor. To selectively inhibit Toll-like receptor 2 in the tumor microenvironment and in cancer cells, we developed theranostic nanoparticles containing the Toll-like receptor 2 inhibitor CuCpt22 that are selectively delivered to the tumor thanks to the coating with the RGD tripeptide that we have previously demonstrated to bind the integrin alpha V beta 3 that is overexpressed in breast cancer cells and breast cancer endothelial cells. These nanoparticles in vitro are more effective than the free CuCpt22 in impairing the viability of breast cancer cells. Moreover, to selectively deliver chemotherapy in the tumor, we also developed liposomes coated with the RGD tripeptide containing doxorubicin. And also in this case, we demonstrated that in vitro, this doxorubicin encapsulated into the liposomes effectively decreases the viability of breast cancer cells. When the two drugs are combined together, they are more effective than the free drugs in inducing apoptosis in breast cancer cells, suggesting that they are promising strategies for the development of combined treatment. In vivo, we treated 41 tumor-bearing mice with the combination of the 2 nanoparticles or the single nanoparticles as a control for 5 times. As you can see, both the single treatments were able to significantly decrease tumor growth as compared to control mice, but when they were combined together, tumor growth was even more reduced. And this was accompanied by a decrease in tumor vascularization. And this can be due to the fact that targeting Toll-like receptor 2 inhibits the production of VEGF by cancer cells and so decreases tumor angiogenesis. And moreover, we are now analyzing also a direct activity of Toll-like receptor 2 inhibition on endothelial cells, since Toll-like receptor 2 is also expressed on blood vessels. Moreover, the combined treatment was able to revert the immunosuppressive tumor microenvironment, inducing an increased recruitment of both natural killer cells and CD8 positive T lymphocytes, suggesting that it could also improve the anti-cancer immune response. These results suggested us that the inhibition of Toll-like receptor 2 in association with chemotherapy could synergize with immunotherapy. As a proof of concept to test our hypothesis, we decided to combine this treatment with vaccination against XCT. XCT is an antigen that we have identified as overexpressed in breast cancer. It's an antiporter that mediates the import of cystine into the cells in exchange with glutamate. In the cell, cystine is reduced to cystine, that is the limiting product for the synthesis of glutathione, that is the main intracellular antioxidant system that prevents redox imbalance, thus protecting breast cancer cells from senescence, differentiation, autophagy, and ferroptosis. In the meanwhile, the exported glutamate can bind to metabotropic receptors that promote tumor growth and invasion, and also bind the receptors on T regulatory cells that favor their activation, thus promoting against the generation of an immune suppressive tumor microenvironment. In the past, we have developed several vaccines targeting XCT that are effective in preventing metastasis in preclinical models of combine the treatment of 41 tumor-bearing mice with CUCPT22 and doxorubicin together with a DNA vaccine targeting XCT that is based on a viral vector, that is the bovine herpes virus 4 vector for the delivery of XCT DNA into mice. As you can see, also in this case, both the anti-XCT vaccination and the treatment with doxorubicin and CUCPT22 significantly decreased tumor growth as compared to control mice, but when the two treatments were combined together, tumor growth was almost completely abolished. And the combined treatment significantly increased the survival of the mice as compared to the control and to the mice treated with the single therapies. Moreover, all the treatments were able to significantly decrease the generation of spontaneous lung metastasis by 41 cells. This was accompanied by a decrease in cancer stem cells in the tumor and an increase in the infiltration of both CD4 and CD8 positive T cells in mice treated with XCT vaccination in combination with doxorubicin and Toll-like receptor 2 inhibition, suggesting that this combined therapy is able to induce a strong anti-cancer immune response. And indeed, this combined treatment induced the production of antibodies targeting XCT that are able to induce ADCC on breast cancer cells at higher levels than in mice only vaccinated with XCT. Again, confirming that the inhibition of Toll-like receptor 2 in the tumor microenvironment helps to generate a more anti-cancer immune response, and so that it could synergize with immunotherapy. So to conclude, I hope I convinced you that Toll-like receptor 2 promotes breast cancer progression via both cancer cell autonomous and non-autonomous mechanism, because it induces also immune suppression, that chemotherapy induces the release of HMGB1 and other dumps by breast cancer cells, and that these dumps activate Toll-like receptor 2 dependent survival pathways, that Toll-like receptor 2 can also contribute to breast dysbiosis-induced tumor growth and chemoresistance, and that therefore the inhibition of Toll-like receptor 2 restores the sensitivity to doxorubicin and to other immunogenic cell death-inducing drugs. Thus, the combination of chemotherapy, Toll-like receptor 2 inhibition, and immunotherapy potentiates their anti-cancer effect and represents a promising strategy to treat breast cancer. And all my collaborators, in particular Antonino, Elisabetta, and Chiara, who did most of this work, all the members of the Laboratory of Oncoimmunology in University of Torino, all our collaborators in University of Torino and University of Parma, the founding agency, and you all. Thank you.